Welcome back for part 2 of the peripheral nervous system. We are going to start off with cranial nerves. Again, our cranial nerves are the nerves that come directly off of the brain or the brain stem, and then they travel to different parts of the head, some of them to the neck, even down into our visceral or abdominal cavity. We have 12 total. There's pairs, one right and one left. There's 2 to the forebrain, and then the rest come off of that brain stem specifically. Most of those nerves are going to be mixed nerves, so we get some sensory, some motor, but we do have 2 pairs that are purely sensitive. They're numbered 1 through 12, and they're named from rostral to caudal. So from towards the front of the brain to the back of the brain. They're labeled in order that they are found. And their names. Here's a couple different mnemonics to try to help remember what their names are. It says, on occasion, our trusty truck acts funny, very good vehicle anyhow. Or, oh, once one takes the anatomy final, very good vacations are heavenly. Well, let's go through these. Cranial nerve 1 is our olfactory nerve. This one is purely sensory because it detects smell. So there's no nerve fibers that need to move anything. It just needs to be able to detect whatever is you are smelling. 2, optic. Optic is another sensory nerve. Oculomotor. Well, it moves the muscles that are attached to the eye. Trochlear, trigeminal. 6 is abducens. 7 is facial. 8 is vestibulocochlear. Glossopharyngeal is 9, vagus is 10, accessory is 11, and hypoglossal is 12. So let's go through these. Cranial nerve 1, olfactory. Olfactory is for smell. It's just sensory to smell. Optic. I also said optic is sensory. For vision, it detects light, colors. Well, it transmits all of that information. Oculomotor, 3, it's motor. Also has parasympathetic fibers to that oculomotor. Trochlear is purely motor. Trigeminal has sensation, sensory, and motor. 4, abducens. Abducens goes to one of the muscles to the eyeball, so again, it is purely motor. Cranial nerve 7, facial nerve. That facial nerve does sensory because it helps with taste, but it also has motor fibers because it helps to move the muscles of your face. And it has parasympathetic fibers. Vestibulocochlear. Hearing and balance. Vestibulo, that's balance. Cochlear, that's where the cochlea, it goes to the cochlea in the ear that works with sound. It does some motor. Glossopharyngeal. All 3. Vagus, all 3. Accessory is purely motor. That actually goes out to your neck. Accessory does. Hypoglossal moves that tongue. So it's going to be motor. So let's go through each of them in a little more detail. That olfactory nerve, as we talked about, has sensory, purely sensory. because it goes through that cribriform plate and the ethmoid bone. It sends little fibers, nerve endings down into there to detect smell. So it is purely sensory of smell. So here you can kind of see all the little fibers coming down from this olfactory nerve that says it's the filaments. Those are just the little fibers that come down. Clinical testing. Usually you have somebody smell something, cinnamon, vanilla, cloves, closing their eyes, have them smell and see if they can detect what it is. Cranial nerve 2, optic nerve. That comes from the it goes to the retinas. It's going to, remember from the central nervous system, that vision centers are in the occipital lobe. So even though it's from the front, it goes all the way back. It travels through optic canals. They converge. Some of the fibers will cross over at the optic chiasma. It goes to the thalamus, where they will synapse with another neuron. Then they go through what are called optic radiations all the way to that visual cortex in the occipital lobe. Again, that optic nerve is purely sensory because it helps us to see, helps us to detect what's going on visually around us. So here is our eyeballs. You see the optic nerve that comes off of the back. Here's this optic chiasma. And see some of the fibers cross while some of them stay. When we get to the vision chapter, we'll learn exactly how that happens. We have the optic radiation, fibers that come out and around, and they all go into that visual cortex. Oculomotor nerve, cranial nerve 3. We have, as I've mentioned before, we have 6 muscles that attach to the eyeball to help you look many different directions. Well, oculomotor, it says what it does. Eye, motor, well, it's going to move the eyeball. Well, it goes to 4 of those 6 eye muscles. It also helps raise the eyelid. It has, remember from that chart, it had parasympathetic fibers? It's your parasympathetic fibers that constrict that iris and that pupil. Those parasympathetic fibers are also going to help with the shape of the lens. So you can see, so you can focus in on different objects. So this oculomotor nerve comes in and it goes to 4 of the different eye muscles. Trochlear. Cranial nerve 4 is trochlear nerve. Trochlear nerve is also going to provide motor to the eyeball. It does superior oblique muscle. That is the only muscle that this nerve innervates. So it goes to superior oblique. You can kind of see is this muscle that comes up here, loops around and connects to the side of the eyeball. Trigeminal nerve. Trigeminal nerve has 3 different parts to it. It is considered the largest cranial nerve, but it has an ophthalmic that comes out of the little hole that's above the eye and the skull. That's at superior orbital fissure. That is where ophthalmic division of trigeminal nerve comes out. We have a maxillary. You can guess where that comes. around that maxillary bone. Same with mandibular. Sure, you can guess where that comes from, or that is to the mandible. It gives us sensory information around the face. The mandibular branch provides motor for mastication or to chew. Mastication is this, it means to chew your food. So here's all the different divisions, what they do, how to clinically test some of this stuff. And you can see each of the different divisions and where information, where sensory and or motor may be supplied. Abducens, cranial nerve 6. This nerve specifically innervates just the lateral rectus muscle of the eye. So it comes out and it'll go directly to that lateral rectus. That lateral rectus is the one here that's been cut, but it goes through back here. And that abducens nerve, cranial nerve 6, goes directly to that muscle. Facial nerve. Facial nerve provides motor to the face. And then it does some sensory too. But this is the main motor nerve of the face. So I think I mentioned before, it's the nerve of facial expression. It lets you make whatever faces you make whenever you make them. It also has parasympathetic that goes to that lacrimal and your salivary glands. We also get taste from the anterior 2/3 of the tongue from that facial nerve. So that facial nerve is going to provide a place for taste because we need to be able to taste whatever we are putting in our mouth to know if it's harmful or not. So here is that facial nerve. There's ways to test that. There's ways to test all 12 cranial nerves, and you can get it done in under 2 minutes usually. But here is that facial nerve. Here's this picture down at the bottom of somebody's hand covering their face. That is literally how each branch of the facial nerve comes out. It really does. As you can see how you get the temporal branch, the zygomatic branch, so that's around the zygomatic bone, the buccal that goes towards above the lip, the mandibular that goes below, and then the cervical goes to the neck. You don't need to know each specific portion, you just need to know that that is cranial nerve 7 and it's motor to the facial expression muscles, and it provides taste to the anterior 2/3 of the tongue. Vestibulocochlear nerve, cranial nerve 8. It splits into 2 divisions when it gets to the ear. We have a division for hearing. That's that cochlear division. Then our equilibrium or balance. That is the vestibular division. It's mostly sensory. It has a little bit of motor because it can adjust the sensitivity of the receptors. When we get to the special senses, we will look at how we have different muscles that can be adjusted based on how loud or how quiet sounds are. But it's mostly sensory because it's providing hearing. It's providing your balance of where you're at in space. So here is the interior portion of your ear. As you can see, we have different parts. It splits to the cochlear nerve that goes to this cochlea right here. And then we have the vestibular nerve that goes to this portion right here. Vestibular is balance, equilibrium. Cochlear is doing hearing. Glossopharyngeal nerve kind of does what it says. We're going to get motor, part of that tongue. Glosso for tongue. Pharynx, it does swallowing, but it also parasympathetic for that salivary carotid salivary gland specifically. It also does some sensory because glossopharyngeal will do some taste from that posterior tongue. It also has chemoreceptors that go to the carotid arteries and those baroreceptors at the carotid arteries. Because we need a place for our nervous system to track and monitor the blood chemistry and send that information to the brain, which then can release hormones or send out signals to alter if something is off. So here is that glossopharyngeal nerve. You can see how it is going to that huge carotid gland. It is also providing motor to that and sensory to that tongue and your pharynx. Vagus. Cranial nerve 10. We're going to keep talking about cranial nerve 10. You'll hear about it in anatomy 2 a lot. So, vagus nerve. It's going to regulate your heart, your lungs, and your abdominal viscera. So it's going to carry impulses from your entire thoracic and abdominal baroreceptors, chemoreceptors, and it even has taste buds. It goes to taste buds at the posterior portion of the tongue as well, and the pharynx. We have taste buds that go all the way back to the pharynx. So vagus nerve does a lot. So in anatomy 2, you'll hit it up in cardiology, respiratory, and digestive systems. So that vagus nerve is a pretty important nerve. It does a lot of stuff to regulate our organs outside of that central nervous system, your brain. So as you can see, this cranial nerve 10, it comes out. It's going all over the place. It goes to arteries. It goes to your heart, your lungs, your liver, your kidney, your spleen, your stomach, your colon, your small intestine. It goes everywhere to help regulate all kinds of things. That accessory nerve. I learned it as spinal accessory nerve. Now they just call it accessory nerve. So the name changed pretty recently. It comes from C1 to C5 of the spinal cord, technically. The rootlets, these little ventral rootlets, they're little tiny nerves that come off of that spinal cord. They go back up into the skull and they're going to come back out at that jugular foramen. It's kind of interesting. But the trapezius muscle, that sternocleidomastoid muscle, those two muscles are actually innervated by the accessory nerve. So you see all these little rootlets here, these little yellow rootlets. This is what makes up spinal accessory nerve. Here's the kind of strange thing, because it's all coming out of that spinal cord. They go back up into the skull to come back out to innervate the muscles. Our last cranial nerve, hypoglossal. Hypoglossal nerve, intrinsic and extrinsic muscles of the tongue. Well, it's going to help move your tongue. It's going to allow you to swallow. If you notice when you talk, your tongue moves. So, of course, it's going to participate in speech. So here you can see this nerve that comes out goes to the tongue, goes to the muscles that make up the tongue, all to help chew and speak. So here is this again. Now that we looked at each of these nerves, we have that olfactory nerve, the optic nerve. And see where the oculomotor nerve comes out through here. Below the oculomotor nerve comes the trochlear nerve. Then comes trigeminal. Abducens, because now we're traveling from medial out to lateral. Well, what's next to abducens? Abducens is 6, so facial nerve must be 7. Next to that, the next to that again is vestibulocochlear. Now we're going back down again. Glossopharyngeal, vagus. You notice how big vagus is? Because it goes to a lot of places. That accessory nerve. And then we come back up a little bit to get to hypoglossal. So all of these nerves work to help your face move, sense, provide sensory, provide parasympathetic fibers to allow lots of different things to happen. So here's this chart again. You can use it to kind of help you just determine which cranial nerves do what. So let's look at what our cranial nerves are made up of. We've talked about it with other nerves, whether they're motor, sensory fibers, and where the neuron cell bodies even are. So let's look at where these cranial nerves, olfactory and optic nerves. That's cranial nerve 1 and cranial nerve 2. The cell bodies for cranial nerve 1 and 2, olfactory and optic, are actually within the special sense organs. So they're within the eye or the pathway for that optic nerve, or they're right at that olfactory bulb at that cribriform plate of the ethmoid bone. 5, 7, 9, and 10. They have sensory information. We have a cranial sensory ganglia that holds their cell bodies. Some of those mixed cranial nerves that have somatic which is motor, and autonomic fibers. They're in that ventral gray matter of the brain stem. Ventral is the anterior portion. And then we have autonomic motor neuron ganglia. If you want to remember the function of the cranial nerves, here's another mnemonic. S for sensory, M for motor, B for both. Some say marry money, but my brother believes it's bad business to marry money. If it helps, great. If not, find something else. Let's go to our spinal nerves. We have 31 spinal nerves. Again, those spinal nerves travel the length of that spinal cord and come out between the two vertebrae, the one above and one below. They are all mixed. And they are specifically named for the place where they come out. We have 7 cervical vertebrae, but we have 8 cervical nerves. Because we have one that comes out at above C1 and then all the way down to below C7. Then it turns to thoracic. We have 12 thoracic nerves, 5 lumbar nerves, 5 sacral nerves, and 1 coccygeal nerve. So as I said, we have those 7 cervical vertebrae. Here's those 8 cranial, or those 8 cervical nerves coming out. 1 through 8. The other side shows how they kind of branch and connect together. Kind of cool. Each set of spinal nerves are going to have ventral roots and dorsal roots. Ventral is the front, dorsal is the posterior portion. Ventral are motor fibers, dorsal are sensory fibers. So sensory comes in the back, motor goes out the front. The cell bodies of those sensory neurons are in that dorsal root ganglia. The ventral roots, those motor neurons are going to go to skeletal muscles. They are branched, the separate little rootlets, but then they come together and form those specific spinal nerves. So here is how you see these ventral rootlets at the front, the dorsal rootlets in the back of sensory motor in the front. So these, motor ones are going out. Then we have sensory that's coming in. Here's that dorsal root ganglia that has all of the neuron cell bodies. They're coming into the spinal cord. If you notice, we also have this here. We'll go into more detail about it when we get to the autonomic nervous system, but those are sympathetic trunk ganglia. So we have sympathetic neurons that travel the length of parts of our spinal cord. They sit outside the actual spinal cord, so that spinal column, I should say. So those nerves that are coming out, they're coming out between the 2 vertebrae. So they're coming out between that top one and that bottom one. They have what's called that intervertebral foramina. Foramina is that opening between the 2 vertebrae. Those spinal roots, they get longer as we get further down that spinal cord. That is where, when I pointed out that spinal cord on the central nervous system, After the spinal cord ends at about L1, L2, it turns into a cauda equina, means horse's tail. Just a bunch of nerve fibers are left. The spinal nerves are pretty short. If you think an inch is 2.54 centimeters, so it's not even an inch long. They usually divide as soon as they leave that foramen. We have a dorsal ramus, a ventral ramus, and a meningeal branch. Meningeal branch, you remember from central nervous system, when we talked about the meninges? Well, those meningeal branches go out and they come back in and they innervate the meninges that that surrounds that spinal cord. We also have what are called rami communicants. These are autonomic fibers, and they're going to go to that ventral rami in the thoracic region. So let's look. We're sliced somebody right in half. You can see this dorsal ramus. Dorsal goes back. Ventral, well, ventral is going to travel towards the front of the body. You can see how small that spinal nerve really is, just right there. We have those rami communicants. You can kind of follow them down to that sympathetic trunk ganglion. And you can see this ventral root. This is following the rib cage around. So as nerves come out of the spinal cord, they're going to enter muscles at different regions from the neck down. Dorsal rami go to the muscles in the back. Ventral rami go to the muscles towards the front and your limbs, your arms and legs. Roots lie medial to and from the spinal cords. The roots are sensory or motor only. Remember when we looked at that picture coming out? Where was that good picture? Here. That ventral root, that's motor because it's coming out from the front. This portion right here, this is purely motor. That dorsal, this is strictly sensory. They're coming back in to that spinal cord. So at that point, they are strictly motor or sensory. They come together to form that spinal nerve. And once they come together to form that spinal nerve, they are a mixed nerve. Sensory information's coming in, motor information's going right back out. So all of our ventral rami, except in our thoracic region, our T2 to T12, that whole thoracic region, they're going to form nerve networks that are called nerve plexus. We have a cervical, a lumbar, and a sacral nerve plexus. We have a brachial too. Cervical, brachial, lumbar, and sacral. And they kind of, remember that picture I showed before, how the nerves kind of crisscross and come together and join other nerve branches that come to go to different places? That way something happens to one specific branch, there's other nerves going to that same area to help pick up the slack. It prevents paralysis. So that's cervical plexus, C1 to C4. They're mostly cutaneous nerves in the cervical plexus because they're going to innervate the skin of the neck, the ear, the back of the head, the shoulders. We also have the phrenic nerve. Phrenic nerve is C3, C4, C5. Phrenic nerve goes to your diaphragm. I had a teacher in school teach me that C3, 4, 5 keeps you alive. Well, C3, 4, 5 goes to your diaphragm. It helps your diaphragm move. If your diaphragm doesn't move, you're not alive. So that's a nice little saying. C3, 4, 5 keeps you alive, and C3, 4, 5 is the phrenic nerve. So here is that plexus that comes out of the cervical region from C1 all the way down to C5. And you can see this phrenic nerve got parts of 3, parts of 4, parts of 5 that head on down. And it's going down to that diaphragm. So here's what the cervical plexus kind of goes to around different regions of the neck and the head. So you know what causes hiccups? You get an irritation of the phrenic nerve somehow. Something causes it to kind of irritate, and it'll cause spasms of the diaphragm. So you get those muscle spasms going in that diaphragm, and that causes hiccups. If both phrenic nerves, so we have one on the right and one on the left from C3, 4, 5, or if between C3 to C5 region of the spinal cord is destroyed, that diaphragm becomes paralyzed. The only way to stay alive is a mechanical respirator, because something needs to breathe for that person to stay alive, because their diaphragm does not work. The brachial plexus. This is what goes to your arms. Brachial is for arm. So we get C5 to C8. Once in a while, C4 butts in there, not with everybody, just because every person is a little different. So sometimes C4 gets in there, sometimes it does not. Sometimes we get T2 in there. Again, not everybody is the same. So our brachial plexus is split up into roots, trunks, divisions, then cords. Let's look. The roots, here in blue. That is where the nerves are coming out from the spinal cord. Some of them kind of join together to go to different places. They start to. Trunks. By this point, we have 3 major nerves. And then they split into an anterior and a posterior division. Anterior goes down that anterior part of the arm, posterior division goes down that posterior part of the arm. So that radial nerve, that's part of that posterior division, goes down the back side of your arm when you're in anatomical position. The median nerve and the ulnar nerve, those are going to go down the front of the arm at places. The ulnar nerve will move towards the back in a place because if you when you bump your elbow on something where you hit your funny bone, you're hitting your ulnar nerve. So here's a chart that shows C5, C6 make the upper, C7 makes the middle, C8 and T1 make the lower. Then for the trunks, and then it divides into anterior, posterior, anterior, posterior, anterior, posterior. 2 anteriors from C5 and C5, C6, C7, make a lateral, and then we get a medial, and then the three posteriors come together to make that posterior part. The posterior goes to the radial and the axillary. The medial goes to the ulnar specifically, and the lateral and the medial go to the median and musculocutaneous nerve. So what do these different nerves innervate? Axillary, well, what muscles are right at that axillary region or your armpit? That deltoid muscle is. Teres minor. Axillary actually innervates the skin in there and that whole joint capsule. Musculocutaneous. That's biceps brachii, brachialis, coracobrachialis, and the skin of the lateral arm. Median. Most of your flexors in your forearm. Pronators, allows you to pronate your arm. Wrist and finger flexors. Thumb opposition muscles. That median nerve is the nerve that gets caught in carpal tunnel syndrome, because that is the nerve that goes through the carpal tunnel. Ulnar. Flexor carpi ulnaris, flexor digitorum profundus. Most of your hand, intrinsic hand muscles, and the medial aspect of the hand, wrist, and finger flexion. Radial nerve. All your extensor muscles, because that's on the back of your arm. Radial nerve goes down that back. Supinators. The posterior skin of the limbs. So here is all of those nerves. Do you see that ulnar nerve? Let's look. See how it goes posterior right behind that bone? So I said if you hit your funny bone, that's the nerve you're hitting. That's the nerve you're irritating right there. We have our median nerve. Whoops. That median nerve is coming through right here. This is going through the carpal tunnel. That's what causes carpal tunnel syndrome. Here is a really good dissection of a cadaver that shows this brachial plexus, and it's laid out very, very well. Because you can see that lateral cord, that posterior cord, that medial cord that branches off to the musculocutaneous, axillary, radial, median, and ulnar nerves. And see where all of those go. Here's all the nerves, the branches that the cord levels that make up each of those nerves, and all the different structures that they go to. Injuries to that brachial plexus, it's kind of common. It can cause a weakened or paralyzed upper arm or upper limb. You stretch that plexus like a football player. Something that falls on the top of your shoulder and pushes your humerus down. Something happens to that median nerve, it's hard to grasp, hold on to something. That's carpal tunnel. Like I mentioned, carpal tunnel, that median nerve is compressed in that carpal tunnel. And it's actually the causality of wrist slashing and suicide attempts is cutting that median nerve unintentionally. Ulnar nerve, as I said, very vulnerable to injury because it sits right at that open bone. You can lose sensory if that ulnar nerve gets damaged. Paralysis, even muscle atrophy. You can get what is called claw hand, where you can't hold on to something well. That funny bone is that ulnar nerve, as I've said. It makes your fingers tingle even. It sits at that medial epicondyle. That's why we can smack it and cause that funny bone pain type sensation. Here is claw hand. This is what this kind of looks like. If that median nerve gets damaged, it affects the muscles that that nerve goes to, and this is what the resulting factor is. If something were to happen to radial nerve, you can't extend your hand at the wrist. So you end up with wrist drop because you can't move your hand up. If you don't use crutches correctly, it'll compress that radial nerve. There's also what's called Saturday night paralysis. Yes, there is really something called Saturday night paralysis. It's after you go out and drink and party all night, you fall asleep with your arm on a chair, resting your head on that arm all night. And it cuts off blood supply to that radial nerve, and it causes numbness, tingling. Can cause you to have that nice wrist drop until adequate blood supply has been replenished and nutrients have been replenished to that radial nerve. So here's that wrist drop. You can't pick your wrist up. Your wrist cannot be flexed back to its normal position. It cannot go there. We have a lumbosacral plexus that serves most of your legs. We have a lumbar plexus technically and a sacral plexus. They have a lot of overlap, which is why it's called lumbosacral. Most of it goes to your legs, but we still have some that come around to our abdomen, our pelvis, and our gluteus muscles, or buttocks. So that lumbar, of course, is going to be from the lumbar vertebral area, L1 to L4. That goes to your thighs, your abdominal wall. That's psoas muscle. The two nerves that come out of the lumbar plexus is the femoral nerve and the obturator nerve. So that femoral nerve, it's your quadriceps and sensory to that skin. Obturator. Remember learning that obturator foramen? Well, that nerve passes through there. It goes to those adductor muscles. See how everything starts to connect. Here is that lumbar plexus. See the nerves that come out, how they branch together, how some of them come together to form different nerves from different levels. How they all come together. Here is that lumbar plexus. You can see how far down some of these nerves actually go. We also have the sacral plexus. Sacral starts at L4 and goes through S5. You're going to get all your gluteal muscles, your lower limbs, pelvic structures, and your perineum. The perineum is the area on the underside of the trunk. That's sacral nerve, or sciatic nerve, sorry. That's the longest, thickest nerve in the body. It's huge. I don't think any of our cadavers are dissected out far enough to see that muscle, but that nerve is huge. There's muscles that are blocking that nerve. They didn't dissect it down far enough to see. But that's what gets our hamstrings, adductor magnus. Most of the muscles of your leg and foot come from there. We get tibial nerve, and common fibular nerve comes from that sacral plexus. So here is that sacral plexus. We saw those sacral foramina. Well, that's where the nerves come out. You can see The sacral plexus, it goes all the way down to the bottom of the foot. I've talked about how there's nerves that go down to that big toe. Well, here's where we find that. Here is that sciatic nerve in a cadaver. Just look how big this sucker is. That is a big nerve. So it serves a lot of different places, and it gives off branches that just keep innervating more different places throughout the legs. So here are all the nerves that comes out of that lumbar plexus, the roots. So what nerves where they come out that make up that nerve and what they innervate. And then here is the sacral plexus. Because you get L4, L5, S1 to S3 that makes up that sacral or sciatic nerve. That's a lot. Here's that cervical plexus. Well, it shows you the map for all of them. So we get the cervical, the brachial, the lumbar, and the sciatic nerves that come out of, or the sacral plexus that comes out of that, the sciatic nerve that comes out of the sacral plexus. There we go. What happens if something happens to that lumbar plexus? Those spinal roots, you gait problems. So the way you walk is not, it's messed up. You may not be able to pick up your leg right. You may not be able to push off of your foot the way, you may not be able to roll through your foot walking correctly. You can get pain and numbness. Your femoral nerve, that is what allows you to move your hip and extend your knee out. The main cause of problems to that lumbar or sacral plexus is a herniated disc that is actually pushing on a nerve somewhere. That obturator nerve, that can be painful in their medial thigh. So there's different nerves all around the body that cause problems in different places. Sciatica. If you've ever heard somebody say they have sciatica before, it's where they get pain that radiates down the course of that sciatic nerve. Usually it travels down the back of their leg. That's some kind of pain, radiating like lightning bolt sensation type pain. Could be a deep, dull pain. Could be because somebody fell. Disc herniation. Somebody didn't inject something into the buttocks correctly. It could be because of spasming muscles. That sciatic nerve comes out one of three ways. We have our muscle here, that nerve can come out above it. It can come out below it. And if you're one of the lucky, not so lucky 10, 15%, it can come through the middle of that nerve, that muscle. And if it comes through the middle of that muscle, it's going to cause a lot more problems. And unfortunately, there's no way to find out if it comes out through the middle unless they cut you open and slice the muscles to get down there and see. So what happens if the sciatic nerve is transected? Your leg cannot move. You are paralyzed. You can't move your foot or ankle. You get foot drop, which means you cannot flex your foot, your toes towards your shin. You cannot do that, and that is called foot drop. Just like any other injury, the recovery from a sciatic nerve injury, it's slow. Sometimes it's never complete. You don't always get back to normal or what your normal is. Depending on where it is, if it's below the knee, your thigh muscles are spared, so you can still kind of pick up your leg. You may not be able to do much with it, like it won't, you'll kind of plop back down, but if that tibial nerve is injured, you cannot flex your foot up, so you take your toes up towards your shin. So you kind of end up with like a shuffling type gait because you can't roll from heel to toe when you walk. You're kind of shuffle along because you can't actually move your toes, and your toes don't pick up. That's what causes that shuffling gait. You can pick your heels up, but not your toes. So let's look at what the nerves of the thoracic region does. Now that we looked at the cervical, lumbar, and sacral nerves. The thoracic, those ventral rami. Ventral, the ones that come out of the front, they innervate muscle because they're motor nerves. We have a lot of intercostal nerves. T1 to T12 supply the muscles of the ribs. We have muscles that lie between each of those ribs. Those nerves come around and go to the thorax, the abdominal wall. We have a very tiny T1 nerve in our T12 is a subcostal. Sub is below. So it's below their ribs. Our back. We have those dorsal rami. And those will help innervate muscles in your back, the skin, from wherever levels that spinal cord comes from. That is where we get what are called dermatomes. Dermatomes are sensory regions. They are innervated by cutaneous nerves of a single spinal nerve. All of our spinal nerves except C1 will participate in a dermatome somehow. We can figure out where a spinal cord injury might be by checking the dermatomes. There's ways to check every dermatome to make sure that it is working. But a lot of our dermatomes do overlap, which is a good thing for a good reason. Because if these dermatomes did not overlap, if we had destruction of a single nerve, we could not compensate and we'd end up with this weird numbness. So here is a dermatome map. As you can see, where the nerves come out, you get C2 at the top of the back of the head, C3, 4, 5, 6, 7, 8. You can see how they go down the arms. Then all the thoracic region, how it goes on they go around the back, around the front. Lumbar, how those go down the leg. Even the back of the leg, you get the sacral nerves. So those all come down, and you see the bottom of your foot is L4, L5. There's a little bit of S1 on the outside of the side of your foot. What about our joints being innervated? Our joints need to be innervated as well. We use Hilton's law to look at how our joints are innervated. Hilton's law states that any nerve serving a muscle that produces movement at a joint also innervates that joint and skin over that joint. That is what Hilton's law means. So any nerves that go to my knee, like the patellar reflex that the doctors check, that's L4 specifically. So when they hit that patellar tendon, they're checking their L4 nerve specifically. So L4 innervates that tendon, it innervates that joint, it innervates the muscles around that joint as well. So that is what that is specifically stating. So let's look at motor endings and motor activity. So motor endings, that's part of that peripheral nervous system again. We release neurotransmitters to those muscles. We talked about that when we got to muscles. But these motor endings, they're also going to go to visceral muscles. So the smooth muscle. They're even going to go to the glands around your body to help innervate the glands to release hormones or whatever their contents could be, like sebum from sebaceous glands or the sweat from sweat glands. Even the digestive acids that come in your, say, your parotid gland, the different glands that go to your mouth. So we have that neuromuscular junction that we talked about when we talked about skeletal muscles. Skeletal muscles use acetylcholine to innervate or to nerves communicate with muscles using that acetylcholine. As we went over that in the muscle chapter, acetylcholine binds to those receptors on the muscle, which opens those specific receptors, which allows sodium to go into the cell, which will eventually open up different receptors to let a potassium go out of the cell. It causes that depolarization of that muscle cell, which causes that muscle to contract. That's why an action potential to a muscle cell causes a muscle contraction. We have all the different steps that come together that allows your muscles to work. We also have autonomic motor endings. Those are those nerves that contain autonomic fibers. We have visceral effectors, and they're simpler than those muscles, how they connect. We kind of looked at this as smooth muscles, but we have varicosities, which are nerves that have lots of branches that attach to each cell. They're going to release acetylcholine and norepinephrine. Their responses are slower. It takes a smooth muscle longer to contract than a skeletal muscle, but they hold the contraction longer as well. So we've kind of talked about with the central nervous system. Let's look in some more detail. We've got our cerebellum and basal nuclei. Those are what plan out and coordinates your movement. Remember, information that is coming into your cerebellum kind of puts everything together of what's happening in the body. Where you are in space at this exact moment is being sent to your cerebellum so it can plan how to move the next, whatever your next movement may be. So we have a segmental level, projection level, and a pre-command level as this information comes out. That segmental level is going to be at that spinal cord. Projection level is at the motor cortex. And instructions to the spinal cord motor neurons are going to be sent from that projection level. But we also have the pre-command level, which is that cerebellum, and that basal nuclei. That is the highest because it modifies whatever information is coming out of the the projection level. There we go. It kind of comes in and modifies that information so that, because that projection level could be saying, okay, let's run. Put left foot, right foot, but how? That pre-command level tells you how to do it based on what you're already doing. So again, that segmental level is that spinal cord. It's the lowest level of motor hierarchy. We have those circuits of the ventral horn neurons, ventrals in the front, and the front part is motor, so it's going to stimulate muscle groups. We have central pattern generators. They help to control the way you move in specific repeated motor activity like walking, running, even writing. So we have inhibitory and excitatory neurons. And they are either excited or inhibited based on how the next part of the movement is supposed to happen. Those projection level, that's those upper motor neurons. So they're not the motor neurons they're the motor neurons that are higher up before they synapse and come out of the spinal cord. They're part of that pyramidal section or system in the brain. We have a brainstem motor area, and it helps to control the reflex and CPG controlled type of actions. Sends information to those lower motor neurons. Helps keep that command level informed of what is happening. Pre-command. And that's that cerebellum and that basal nuclei. They kind of regulate and make sure that what activities you're doing them precisely to not cause injury. They start and stop movements well. They coordinate your movements with whatever posture. You're going to block unwanted movement because your motor cortex sends general information. Our cerebellum and our basal nuclei perfect it. They may be sending something that doesn't make sense with what's currently happening in the body. So they're going to block that. And you're going to monitor that muscle tone. That muscle tone is those partially contracted muscles. They perform unconscious planning and discharge in advance of willed movements. While you want to do something, sometimes you got to get to the right position to do something. Well, they're going to make sure you get to that plan, getting to that position so you can do what you want to do. Like a high jump. Well, you got to run and you got to push off of that pole in some direction, some way. So it's got to plan that whole process out. Cerebellum. Cerebellum is going to act on pathways through the projection areas in the brainstem. It's also going to act on the motor cortex, thalamus, and fine-tune motor activity. While the basal nuclei, they inhibit motor centers under resting conditions. So you don't get some weird random jerky movements when you're just sitting on the couch or laying in your bed. That basal nuclei is going to help prevent that from happening. How about our reflexes? We have intrinsic or inborn reflexes. We also have learned or acquired reflexes. Inborn or intrinsic, they're rapid, they're involuntary, but they're very predictable. Because that's how we maintain our posture. Your visceral activities, stuff you don't even know is happening right now, is happening. They can be learned with conscious effort. What about your learned or acquired reflexes? That's what you get from practice, like playing the piano. That's a learned reflex. Playing any musical instrument is a learned reflex. Playing video games, that's a learned reflex. Driving, That's a learned reflex. Pretty sure I've said this before, but the reflex arc. That reflex arc is how information comes in and goes back out for a specific reflex. So we have that sensory stimulus, that receptor that gets triggered. That receptor is part of a sensory neuron. That sensory neuron, the receptor that's at the end of that sensory neuron, gets stimulated. It's going to send the information into the spinal cord, that dorsal horn. It goes into that spinal cord. The integration center will be monosynaptic or polysynaptic. Mono, one, poly, many synapses. So it's going to synapse somewhere within that central nervous system. It's going to send out a motor neuron. It's going to send out information to whatever receptor organ, muscle, and then that effector is going to be that response. So we have somatic reflexes and autonomic visceral reflexes. Somatic means muscle, so it activates skeletal muscle. Autonomic or visceral, well, that's going to be your smooth muscle, your cardiac or glands. So here is how this kind of works. Receptor. Here they're sticking a nail into your skin. I like the use of a reflex hammer because it's the same kind of thing. When you hit that patellar tendon, you get that stimulus that comes in via the sensory. You get hit by that, hitting that patellar tendon. It comes into the spinal cord. You have this interneuron that's going to connect the sensory neuron to the motor neuron, which is going to cause muscles to contract in your leg to kick out. That is how a reflex works. Information may be sent up to your brain, but the actual response to that reflex just goes through the spinal cord and back out. As I just said, those spinal reflexes, they do not involve those higher brain centers, but they still tell the brain what's happening, which is why you can hit that patella and you can check a reflex and see how well that communication system is working without any information actually going up to the brain. That just is checking that entire reflex arc. There's reflexes all over the body, your arms, your legs, even one on the abdomen. So if they're exaggerated, distorted, or absent, it could mean degeneration or pathology of that region of the spinal, of that nervous system. We usually use stretch, flexor, and superficial reflexes. The superficial reflex was the abdominal one. Stretch, well, that's your tendons and your muscles being checked. So those stretch and tendon reflexes, when these are checked, we're looking at, okay, what's the current length of the muscle? Muscle spindles. Kind of saying where that muscle is in space. The tension in the muscle. Those tendon organs. They're sending information into the brain at all times. So we know what all this is. So let's look at what those stretch and tendon reflexes are made up of. These muscle spindles, they're usually skeletal muscle fibers, or intrafusal muscle fibers, and they have a connective tissue capsule around them. There's no myofilaments, they are not contractile. They're there to monitor. They do have some actin and myosin at the end regions. They can contract at the end of the muscle only. The effector fibers are extrafusal muscle fibers. We have annulospiral endings and flower spray endings. Annulospiral, they wrap the ends of the spindle. They determine the rate and the degree of the muscle stretch. While the flower spray endings, there's just small axons. And they're only at the degree, they will always monitor just that degree of stretch. So as I mentioned, there was contractile, there's those actin and myosin filaments at the end regions of these spindles. They are innervated by what are called gamma efferent fibers because they want to monitor the sensitivity of that spindle. The extrafusal fibers that we talked about are innervated by alpha efferent or alpha motor neurons. So here are the different types. You see this muscle spindle. It's in the middle of this muscle, but you have these intrafusal fibers in here in the middle. They have that nice pretty blue. Those are those annulospiral endings. They're wrapped around that muscle to help determine what the stretches of the muscle. The flower spray endings. That is the purple. You can just see there are lots of branches coming out. That is just they are checking the stretch of the tendon so that you can monitor. When the muscle is unstretched, it's relaxed. What is happening versus a stretched muscle? You can see how often a relaxed muscle here is sending information in on what its current stretch is versus a stretched muscle. Oh, look at how much more often this information gets sent in. A lot more often. So when a muscle contracts, it reduces the tension of that muscle spindle because muscle spindles are checking the stretch of the muscle. Well, and since we're contracting a muscle, it's not stretching, it's getting smaller. So tension gets reduced and sensitivity gets lost when we're contracting a muscle. So what happens is these muscle spindles also shorten because of those gamma motor neurons coming in. They also fiber when those alpha neurons fire, which is what goes to the muscles. So we have alpha gamma coactivation that helps to maintain the sensitivity of those spindles during a muscle contraction. So when that alpha neuron is sending action potentials to those muscle fibers to contract, the gamma neurons are also sending information to contract to maintain their sensitivity. So that muscle, our brain knows where that muscle is at any given moment. So this is showing the purpose of the alpha gamma coactivation. Because you see that alpha neuron is sending information saying to these muscles to contract. But sensitivity is lost. So there's no action potential sent to know what's going on. You're unable to send anything. But if the alpha and the gamma neurons are sending information at the same time, they all contract and the sensitivity to those fibers remains the same. Here's that knee-jerk reflex that I've been talking about. The brain sets the muscle lengths with a stretch reflex. That knee-jerk reflex is a stretch reflex. And we want that because it keeps your knees from buckling when you stand up. We want our legs to hold us up, not to buckle and bend and fall over. That's the last thing we want. They maintain your muscle tone, especially when you're standing, sitting up straight. And they can adjust to how you move. And that's why if you bend to the side, muscles will contract on one side and stretch on the other side of the spine. These stretch reflexes make this all possible. So how do these muscle spindles actually do all of this? Well, our stretch reflex gets activated. It activates muscle spindles. We have sensory neurons that synapse directly with alpha motor neurons in the spinal cord. These alpha motor neurons cause extrafusal muscles of stretched muscles to contract. We have reciprocal inhibition that's going to occur where those afferent fibers synapse with interneurons that inhibit alpha motor neurons of antagonist muscles. And that patellar reflex, when you're having that patellar tendon tapped, it causes the stretch of the quadriceps muscle, which causes that muscle to contract. And it's going to cause your hamstrings to reflex. And that's what causes your leg to kind of kick out and come back. These different muscles work together to cause that actual type of reflex. So all of our stretches are monosynaptic and ipsilateral. So they synapse once and they are on the same side of the body. So you hit your right patellar tendon, you're going to get a response on that right side. Just think, if you hit that right patellar tendon, but you got a reaction on the left side of the body, that would make you stop and look like, wait, what's happening here? Let me try that again. Something went weird. So a positive reflex, we get two different kinds of information. We know that the sensory and motor connection are intact. So when you hit something sensory, we get a motor response. That's what that means. You hit that patellar tendon, that's a sensory input. That input comes into our spinal cord, it goes back out as a motor response. And the strength of the response indicates the degree of spinal cord excitability. So are we getting a normal response? Are we getting a hyper response where the leg kicks a lot higher? Are we getting a hypo response where there's not much response at all? That's how excitable the spinal cord is. That all that information we are able to gather just based off of the response that we get when we tap the patellar tendon. What happens if we have those hypoactive or absent reflexes? Could be nerve damage. Which means you hit that patellar tendon, that's that L4 nerve root. Something's happening to that L4 nerve somewhere, either along the way, or it could be a ventral horn injury. Someone with chronic diabetes, neurosyphilis, and coma, they do not have reflexes. What if someone's just hyperactive? There could be problems with the corticospinal tract. Because that corticospinal tract will reduce inhibitory effects of the brain on the spinal cord. There's other reasons for it that is neurology type based. Some people just naturally have always had hyperactive reflexes. It could be due to some kinds of autoimmune conditions that are causing hyperactive reflexes. So part of that just is taking a good history with the patient to find out what's going on before you check some of this stuff and start getting alarmed when it's normal for them. So how does our brain adjust muscle spindle sensitivity? Well, those gamma neurons that go to those muscle spindles, when that gamma neuron gets stimulated, that spindle is stretched and contraction force is maintained or increased. So that muscle starts contracting more based off of stimulation of that gamma neuron. But what happens if those gamma neurons are inhibited? Any information sent from that spindle is unresponsive, so nothing comes back out. And that's what actually allows your muscles to relax when that gamma neuron gets inhibited. A gymnast on a balance beam, that is very important to have your body being able to adjust the spindle sensitivity within your muscles. This is very important for gymnasts specifically, but for all of us, so we can go about our daily activities, moving and walking around as much as we do. What about our tendon reflexes? Our tendon reflexes involve polysynaptic reflexes because we don't want our tendons to pull too much or stretch too much. So their job is to help prevent any kind of damage by maintaining a specific length. They also help control muscle contractions by providing a smooth onset and a termination to muscle contraction. Because if your tendons don't kind of help adjust, when that muscle contracts, it just kind of plops down. There's nothing to kind of control the way your muscle relaxes down. It actually produces muscle relaxation or lengthening in response to tension. Muscle contraction, or passive stretch activates that tendon reflex. We get an afferent impulse transmitted to that spinal cord. That allows that muscle to relax. And those antagonistic muscles contract. Like when you bend your arm for a bicep curl, bending it up, those biceps contract. Relaxing it down, those triceps that biceps relax, the triceps contract. That's reciprocal activation. We need that so we are able to walk and move smoothly. Information is always going to be sent to that cerebellum because that cerebellum helps to fine tune any planning of movement that is coming out of our brain. And it helps to adjust muscle tension so we can do what we need to do efficiently. So here, our quadriceps tendon, your quadriceps muscle is contracted. When that muscle contracts, it activates the tendon organs. Information goes in through those afferent fibers because this afferent goes into the spinal cord. Our efferents are what comes back out, and they impulse it antagonistic muscles. The hamstrings causes them to contract. And those efferent fibers also to go to muscles when they're with stretched tendons and it allows that muscle to relax and reduce the tension to that muscle. So our flexor withdrawal reflex. Our flexor withdrawal has to do with painful stimuli, like touching something hot. Allows you to pull your hand off really quick. Get poked with a needle. But your brain plays a role in this, and it prevents you from doing certain things. Like if you're getting blood drawn and you don't like needles, your brain is what keeps your arm there. You don't pull it away when someone's trying to stick you with a needle. That's the last thing you want. So that flexor or withdrawal reflex, it withdraws your body part for fear of being pain. Touching something hot, it pulls your hand away really quickly. Stepping on something sharp, stepping on a Lego, picking your foot up right away because that hurts. These nerves tend to be polysynaptic because they need to go to lots of different places to allow this reflex to happen smoothly. But as I said, your brain can override that. Blood draws allows you to keep your arm in place even if you know a needle is coming to poke at you. We have a crossed extensor reflex. This crossed extensor reflex, it occurs with flexor reflexes in weight-bearing limbs to maintain balance. It's a ipsilateral withdrawal reflex and a contralateral extensor reflex. Stimulated side is withdrawn or flexed while contralateral side is extended. Stepping on broken glass. Stepping on a Lego. Stepping on your dog's toys. It allows you to shift your weight off of whatever you just put your foot on. Someone grabs your arm and it causes you to go off balance. This crossed extensor reflex allows you to keep your balance. So as soon as somebody pulls at you, you don't fall over. So here's how this works. You step on something, information goes up into the spinal cord, it attaches out to several different neurons, both sides, because you got to be able to shift your weight back over to the other leg to maintain your balance so you don't fall over, but you also need to be able to pick this leg up to get off of what you just tried to step on. That is this crossed extensor reflex because it goes to both sides of the body to allow you to balance. This is another reflex I had mentioned about. Superficial reflexes. It's caused by brushing something up against plantar, the bottom of your foot, and the abdominal. The plantar reflex is known as Babinski or Babinski sign. It is normal up till the age of 1. After that, it is not considered normal anymore. It tests L4 to S1. You stroke the bottom of a baby's foot and their toes are going to fan out. That is Babinski sign. But in an adult, toes should go downward. The abdominal reflex. You stroke someone's stomach on the lateral side, above, below, and both sides of that umbilicus. You're checking T8 to T12 nerves. The muscles should contract and your umbilicus should move towards that stimulus. So what happens if we get a Babinski sign in an adult? Well, as I said, those toes fan out and that big toe or the hallux dorsiflex straight up. And a baby, of course, it is natural because their nerves are not completely myelinated. In an adult, it is not normal. There is a Babinski sign touching a baby's foot and how their toes fan out. It is normal in a baby. So how does our peripheral nervous system develop? Well, as our spinal nerves come out of the spinal cord, they come from those neural crest cells. They're going to exit between the vertebrae as they come, as those vertebrae are developing. That's how we get motor and sensory information out to developing muscles. It helps those muscles actually mature so that we can eventually use them. Those cranial nerves are going to travel to the places in your head and your face to innervate so we can feel, taste, hear, smell, see, all of the above. As that as that body part grows, that spinal nerve is also going to expand with it. As we get older, our sensory receptors don't work as well. Your muscle tone starts to decrease in your face and neck, and your reflexes start to slow. Peripheral nerves, technically they're viable for your entire life, unless they have some kind of trauma. And that is it for the peripheral nervous system. Thank you very much. Bye.